So hepatocellular carcinoma or primary liver cancer is the third most common cause of cancer mortality worldwide. It is reported that there are more than 800,000 deaths a year all around the world. Of course, because 80% of the cases occur in Africa and East Asia, which are developing countries. So there could be underreporting of cases, and the actual number of cases must be much higher. 80% of the cases occur in cirrhotic liver, and in patients with hepatitis B, some patients of non-alcoholic fatty liver disease, and rarely hepatitis C virus related cirrhosis may occur in non-cirrhotic liver. Male to female ratio is 2 or 2 to 4:1, depending on whether one is in high incidence area or low incidence. And the median age of onset is again less than 60 years in high incidence area, more than 60 years in low incidence areas. So if we look at geographical distribution with respect to etiology of hepatocellular carcinoma, we find that in North America, alcohol-related cirrhosis is most common. In Europe, it is hepatitis C related. In Japan, again, it is hepatitis C related. And rest of the Southeast Asia is alcohol, hepatitis B, hepatitis C. The category of others, which includes basically non-alcoholic fatty liver disease, is slowly increasing as a spectrum of HCC in developed countries, and maybe 20-25 years down the line, it could be a major cause of HCC even in countries like India. So how does HCC present? Now, currently, because we are diligently screening most of our cirrhotic patients, we are finding HCCs in a patient who has no symptoms of HCC. So they may be having symptoms of decompensated cirrhosis, ascites, GI bleeding, jaundice, but they do not have classical presentation of HCC. And what is classic clinical presentation of HCC is a patient with right upper quadrant pain who has recent weight loss. And on examination, you will feel a hard mass in the liver. You may hear a bruit over the liver. But mostly our patients present during the screening. Patients may also present to us with recent worsening of clinical status, and that could be an indication that HCC has developed in that patient. Metastatic lymphadenopathy is quite rare in HCC, which can be appreciated on clinical examination. Now, Professor Okuda gave this description of clinical types of HCC. Now, this was a clinico-pathological study. So he had correlated the clinical features as well as the LFTs, imaging, and autopsy of these patients. So in his classification of clinical types of HCC, frank HCC is what I described as upper quadrant pain, mass, and weight loss. But the HCC could also present as only PUO, fever, or it can present as an acute abdomen. This is typical of ruptured HCC, which will come as severe abdominal pain. The patient is in shock. Cirrhotic HCC is the typical presentation as a decompensated cirrhosis than any other feature of HCC. The HCC could also be cholestatic type or hepatitis type, and occult HCC is when it is seen only on autopsy or only on imaging. So clinically, there is no suspicion of HCC. HCC is reported to present with paraneoplastic features like hypercalcemia, clubbing, polycythemia, watery diarrhea syndrome, hypertension, hypoglycemia, but these presentations are quite uncommon. I think the commonest among these would be hypoglycemia in patients with large HCC. Now, Professor Okuda also gave the first staging system for HCC, and it was depending on the tumor size, where 0 points were given for less than 50%, 1 point for more than 50%, with or without ascites, with or without hypoalbuminemia, and with or without hyperbilirubinemia. And he divided the patients into stage 1, 2, and 3. Now, if you see this classification, you will find that he's talking about very large HCCs. See, even 0 point is less than 50% of the liver occupied, and 1 point is more than 50%. And it is not surprising that if you see the median survival as per Okuda classification, so Okuda stage, the median survival is 5 months. Okuda 2, it is 2.7 months, and Okuda 3 is only 1 month. Now, obviously, these patients were diagnosed at a very late stage. If you compare that with the currently used Barcelona clinic liver classification system, and this is divided into very early stage where there is a single tumor less than 2 centimeter. Early stage is 2 to 3 nodules, all less than 3 centimeter. And if you see the 5-year survival in very early and early stages, more than 5 years. Even in the intermediate stage is more than 2.5 years. Only in the terminal stage, the median survival is 3 months. So obviously, our way of looking at HCC or diagnosing HCC and treating HCC has changed remarkably over the last maybe 30-35 years. So is it possible to detect the patients in earlier stage and then offer them treatment so that their survival is extended? Now, in 1968, in a classic paper, Wilson and Jungbert gave the principles of screening. So if a disease condition fulfills these principles in a particular population, then screening is supposed to be beneficial for the population. So it has to be important health problem. Of course, HCC is, because it is third most common cause of cancer-related mortality. The natural history, we will come to that, is known. Recognizable early or preclinical stage, and here we are talking about detecting small HCCs by imaging. Availability of a suitable test which is acceptable to population, again we are talking about ultrasound and a blood test like alpha fetoprotein. And there is acceptable and available treatment policy for that disease, which is also there. And there is cost benefit analysis, which is of course not done in a country like India, but in most of the developed countries, it is found cost effective to screen for HCC. Now, HCC is known to go through multi-step carcinogenesis, typically in patients with cirrhosis. Now, it goes from regenerative nodule to dysplastic nodule to early HCC, nodule in nodule, and then becomes advanced HCC. 20% of the patients where it happens in non-cirrhotic liver, especially in hepatitis B, there could be de novo carcinogenesis, and it may not start as dysplastic nodule. But still, a tumor which is say 10 centimeter has to be 2 centimeters sometime, has to be 3 centimeters sometime. So by screening, we are basically aiming to pick up these lesions in an earlier stage. Now, as far as cost benefit analysis is concerned, it has been proven that if the risk of HCC in that particular kind of patient is more than 1.5% in presence of cirrhosis, or more than 0.2% per year in a non-cirrhotic like hepatitis B patient, it is cost effective to screen for HCC. The risk of HCC among cirrhotics is highest in hepatitis B, followed by hepatitis C, followed by non-alcoholic fatty liver disease. Now, methods used for screening worldwide is ultrasound, which is simple, easily available. As we will discuss later, alpha fetoprotein is also added as part of screening program in certain countries. Generally, the standard accepted frequency is every 6 months, and why every 6 months we will come to later. The aim is to diagnose HCC in an early stage where effective therapy can be offered. So these are the international screening guidelines. There is some variation. Basically, American Society for Study of Liver says that we should screen all cirrhotics except advanced or child C cirrhotic who are not on transplant list, because in those patients, the survival depends more on the advanced liver disease rather than a small HCC in those patients. And most of these patients, any sort of treatment may not be offered because of the general condition of the patient. In Asia Pacific, of course, all cirrhotic patients are there, but hepatitis B is a major problem in Asia Pacific region. So it also gives indications to screen for HCC in non-cirrhotic hepatitis B patients. So males more than 40 years, females more than 50 years, and Africans at age 20 years onwards, because in Africa, it is known that tumors happen at a very young age. Those with family history of HCC again have to be screened. Asia Pacific guidelines mention that sonography should be combined with alpha fetoprotein every 6 months. Now, the reason for that is overall sensitivity of sonography to pick up small HCCs is around between 40 to 45%. And if you add alpha fetoprotein to that, you may increase the sensitivity of screening by another 10 to 15%. So your sensitivity goes to 55 to 60%. That is why Asia Pacific makes it mandatory to do both. American Association leaves it to the physician's discretion whether to add AFP. And we will come to that in which patients one may add AFP. European guidelines say that, of course, cirrhotics, child A and B have to be screened. Child C only if they are awaiting liver transplant. And for hepatitis B, they do not follow the Asian guidelines of age and in Asian males and in Africans. But they go by something called as Page B score. It is a risk stratification score in patients with hepatitis B who can be stratified into intermediate, low, or high risk, and screening is recommended for intermediate and high risk patients. So when we are doing basically ultrasound imaging for all patients every 6 months, if you find a nodule or mass, what is to be done? If it is more than 1 centimeter in size, we go ahead with another multiphasic contrast enhanced imaging like CT or an MR. If that shows typical features of HCC, then we treat it like HCC. If that doesn't show, suppose you do a CT and it doesn't show the typical features, you have the option of adding an MRI again with contrast. And if that shows typical features of HCC, again, you treat it like HCC. If there is any doubt in our mind, and the radiologist, Dr. Amar, is going to discuss about the problems in diagnosis and the LIRADS grading. So if there is any doubt, then one can always do a biopsy to sample the lesion. If biopsy is positive, again, it is HCC. If the biopsy is negative, again, the patient goes back to the screening. And if you are highly concerned about that lesion, then you may do ultrasound every 3 to 4 months instead of going to 6 months. But in a benign nodule, you can go back to every 6 months. Now, this is the LIRADS classification. I'm not going into details about this, but important thing to remember is that LIRADS basically gives the probability of having malignancy, either HCC or a non-HCC malignancy. So in LIRADS 1, the risk is 0%. In LIRADS 2, there is still 13% risk of HCC. And LIRADS 3, it is 38 to 40%. So important thing is that even if the biopsy is negative, some nodules may need a very, very close follow-up, especially if it is LIRADS 3. Or in LIRADS 4, one may have to do more frequent or aggressive imaging. So is there evidence that screening for HCC in cirrhosis is really effective? Now, there are 2 retrospective and 2 prospective studies. Basically, the most important one is the study in a Chinese patient. Basically, they had randomized villages, entire villages. So some villages underwent screening, some villages there was no screening. And they found that HCC, where one could offer potentially curative treatment, was found in 45% in every 6 month screening and where 79% were treatable. And clearly there was difference in the 1 year and 5 year survival when the patient was screened and not screened. There are also studies where patients were screened every 6 months and every 12 months. And again, it is concluded that screening every 6 months is far superior to screening every 12 months. And that is why the recommendation of ultrasound is there in all guidelines. So every 6 months you have to do an ultrasound. In Asia Pacific, you add alpha fetoprotein in the guideline. Americans guidelines, they leave it to the physician discretion to add alpha fetoprotein. Now, this is a very interesting graphs from Taiwan. So they have seen the outcome of patients between 2004 to 2007, which is the blue line, and the recent cohort of patient is 2012 to 2015. And you can clearly see that the survival and those who were offered curative treatment, those who were offered non-curative treatment, and survival in all kinds of patients is far better in the group which was screened and treated between 2012 and 2015. And that is because once you start aggressively screening all these patients, you are going to get patients at an early stage where you can offer curative or at least effective treatments which can prolong the survival. But are these strategies sufficient, or is there any way we can screen better? So risk stratification models have been developed based on host factors, viral factors, and liver factors. Now, host factors is like age, gender of the patient, whether there is family history, does the patient consume alcohol. Viral factors are based on whether it is E antigen positive, the viral load, HBV DNA quantitative, the genotype of virus, what kind of mutations are there. And there are liver factors like liver stiffness measurement, the albumin, the bilirubin, or the alpha fetoprotein level. So there are multiple models which have been developed in different countries. Now, some of these models only look at hepatitis B virus patients, like the page B model, which is mentioned in the European recommendation. There are also models which look at only hepatitis C and stratify the risk into low risk or high risk. And there are also few models which are developed for the general population. General population in the sense for all patients with cirrhosis, whether it is NAFLD, HCV, or hepatitis B. So there are two ways of looking at risk stratification. One is whether we can be super selective and more aggressively screen some patients, like every 3 months rather than every 6 months. Is it necessary? And secondly, there is also a school of thought which says that suppose the risk of HCC is, as I mentioned in the initial slide, 2 to 8% per year. So now, are we unnecessarily screening those who have lower risk every 6 months because it puts a strain on the healthcare system? And should we give priority to higher risk patient? But there is no clear answer to that yet. And only the Japanese Society for Liver Disease, so they will screen extremely high risk patients with ultrasound and 3 tumor markers. So they do alpha fetoprotein L3 fraction, and PIVCA. So that is done every 3 to 4 months along with ultrasound. And CT or MRI is done every 6 to 12 months. Okay, so but cirrhosis due to other etiology, if they feel there is high risk, they will again add tumor markers AFP, PIVCA, and AFP-L3 to ultrasound. So they are selecting some patients who are high risk as per the models, and they are more aggressive about screening these patients. Now, what are the problems? Now, as all of us have seen that the quality of ultrasound is not uniform in all centers across the country. So you must have seen some patients who went for screening and 6 months later came back with a 7-centimeter tumor. So it means that even if the patient is going for screening, some tumors may be missed. Second is that even in countries from Europe or in United States, if you retrospectively see, less than 30% of the patients of cirrhosis are undergoing screening in spite of the guidelines being there. In fact, one American study of veterans administration hospitals said that only 3% of the patients were screened as per the guidelines. So 97% of the patients were not screened even if the guideline is in place. Now, if we consider the factors which are responsible for adherence to screening. So if the patient of cirrhosis is followed up by either a gastroenterologist or a hepatologist, then he is more likely to have a screening religiously every 6 months. Now, here we should remember that the problem lies with the physicians who are taking care of the patient. Amongst patients who are recommended 6-monthly screening, only 3% miss the screening. Okay, so this fact we should remember, that if the screening is not happening, it is the physicians who are responsible. Because once you tell the patient to do screening, the patient does it. So only 3% chance that you tell the patient and patient is not going for screening. Also, there has to be a reliable recall strategy. We should have a system where, suppose it's a doubtful lesion, biopsy is negative, you decide to do another imaging after 3 months, then there has to be some way of contacting the patient to call him back. So coming to the nearly the end of the talk, so this will summarize the whole thing. So screening population is all patients with cirrhosis except child C who are not on transplant list. For Hep B, it is either family history of HCC, Asian males more than 40, Asian females more than 50, and African born more than 20 years. In patients with hepatitis C, again cirrhosis, and those with bridging fibrosis, it is only those who are high risk as per the prediction model. How long should we do the screening? Lifelong for that patient. What is the interval? Every 6 months. And as I said, in some patients, Japanese Society recommends every 3 months, which are considered high risk patients. And what is the imaging modality? Ultrasound is the preferred one, easily available, not very expensive. Alpha fetoprotein is recommended by Asia Pacific guidelines, and it is as per the discretion in American guidelines. But if there is a lesion found, then you always follow it up with a CT, MRI. You may add alpha fetoprotein to it. And depending on the result of this imaging, you follow up the patient. So when we talk about Baywatch, this is the image that general public will get. But when a hepatologist thinks about Baywatch, he remembers David Hasselhoff, who is standing at the watchtower and constantly looking for signs of trouble. And he's looking for early signs of trouble so that he can intervene and save people's lives. So the message of the talk is ultrasound plus or minus AFP every 6 months. Okay, ultrasound is mandatory. AFP depending on the patient, whether we should do it every patient or not. Thank you.